Thank you for coming tonight. My name is Kara Prunty, and I am from the Danbury Health Department. And I appreciate you guys all coming out and spending your sunny afternoon with us to talk about opioids. I'd like to thank Molly from my office for putting this all together and all of our panelists. The mayor would have loved to be here, but there was a glider that crashed into a house. So on behalf of him, thank you for everyone for coming. And I'm going to hand it over to Allison so she can introduce everyone. Thank you.
Thanks for being here.
Lisa, thank you. Welcome, everybody. This is a very lovely evening outside, so I'm impressed that you're here. And hopefully this will be a productive hour and a half. What's this going in now? Hopefully this will be a productive hour and a half for everyone. As you can see, there are plenty of materials to take with you, to take home, to read later on. We have a really great panel. Thank you. We have a really great panel. And hopefully you all took, I'm just going to keep going out.
Hopefully you all took, I'm really loud anyway, it doesn't matter, I really don't need this thing. Hopefully everybody took a note card if you didn't, and a pen, so that if you have questions after the panelists have made their presentations, just jot it down on the index card, and I think Molly is going to come around and pick them up, and then we'll field the questions. So the first hour will be devoted to like 10-minute slots for each of our panelists, and then at the last half hour of the evening, we'll be able to entertain some questions. Okay? And I think we're going to be able to hit most of the topics that are of kind of, priority interest when it comes to opioids. And also, Officer Daniello is going to be talking about vaping as well. All right?
And just in case, I should announce where I'm from too. I work at the Housatonic Valley Coalition Against Substance Abuse, which is a coalition that covers the 43 towns in the western part of the state, and we have an opioid work group. All of these panelists actually participate on that work group and have since like 2014. So I'm very familiar with their work, and I know how committed they are to this issue. And at my office, we really just try to stay on top of all the different substances, not just opioids, but just for instance, today I wanted to read this. We get emails from the state when there's kind of an important alert coming out, and just so happened that in a 5-day period, there was an announcement today, in a 5-day period, in a 15-hour span, the city of Hartford had 5 overdose deaths, or overdoses, not deaths, related to fentanyl. And so when, like large-scale things like that happen, they send an alert, and you know what? It just makes you stop and think about, it could be any community at any time, and this is the stuff that we need to be more aware of, that it could happen here or in a small town just as easily. But it's just important to kind of pass that information along. So without further ado, I'm going to kind of introduce the panel and tell you what their topics are, and we'll start with Vinny, okay? This is Vinny Daniello. He can tell you a little bit more about himself. He's from the Danbury Police Department, and he's going to talk about the law enforcement aspect of this, the prescription drug drop box, and he'll talk about vaping and what's going on with vaping in the community and what we're doing to address that issue. Terry Budlong from MCCA is also the co-chair of the Stand Together Make a Difference Coalition here in Danbury, and she's going to be talking about the signs and symptoms of opioid abuse. Matt Casavecchia is from Danbury Hospital, Western Connecticut Health Network, New Vance Health, thank you. And he'll talk about the emergency medical side of things. So what happens with EMTs and what happens when people are processed through the emergency department after an overdose reversal, etc. Allison Salem is here. She's a patient navigator, and she's just going to talk about her role. This is kind of a new role that's happening all around the state in different hospitals, helping people kind of with warm handoffs and accessing appropriate levels of services should they go into the emergency room, right? You don't do community outreach as well. You're in the ED, right?
I do a little bit of community outreach.
You do both, okay, thanks. So she's going to explain that role and how that's impacting the community. Then Dr. Rosenberg is here, the very esteemed Dr. Rosenberg, who has been and was our first Suboxone prescriber in this area, right? Many years ago when I first met you, like 2002 or something. 3, okay, I was close. So he'll talk about the medicated assisted treatment aspect of things and the myths behind that. And then Eileen Roberts is here. She's from MCCA also. She actually is a prevention core service person, and she's been working with Terry through the Stand Together Make a Difference coalition. She's going to talk about the impact of opioids on the senior community and awareness around that. So without further ado, I'm going to give you this one. This one seems to be working okay.
Sure. Hello everyone, thanks for coming. Lieutenant Daniela from the Danbury Police Department, commanding officer for the Community Services Division, so we do a lot of outreach and talks. As far as law enforcement, the opioid epidemic, we're going to get into a little bit of that, and I'll touch on maybe at the end. It's just really difficult to cover in about 10 minutes because there's a lot of problems associated with that, but kind of what we're doing. When we look at law enforcement as an overall perspective, when we talk to the drug problem or opioid or any type of substance abuse problems, we've kind of tried to take a different approach and understanding, because through the councils I've sat on and the conferences I've gone to and through experience, we're not going to arrest our way out of the issue that we're facing right now. Not to say that we're not actively enforcing the suppliers and how the drugs are actually coming into society. So aside from stepping up enforcement investigations, we have to go a little bit broader, obviously, than just the street level, because it's not there as much as it is through federal trafficking, state to state. So we have stepped up our investigations actually into the opioids. And what law enforcement is doing now is we've teamed up a lot more with EMS and the hospital providers as far as treatment goes for the people who actually A, maybe overdosed, or B, are selling it. I sort of minor sellers, not the major traffickers, the ones that are selling just to keep their habit going. Okay, we're trying to steer them towards different protocols through the hospital system, through recovery coaches, definitely community teams, as far as the community care team. I don't know if many of you are aware of the situation with that. It's a collaborative between numerous city agencies throughout the greater Danbury area who would take, it's a collective of invested parties from the greater Danbury area who improve outcomes for the vulnerable populations, right, including those who are currently mentally, physically ill, homeless, or abusing substances. Right. Officers will bring potential candidates to this board to try to navigate the problems associated with substance abuses, the homelessness, the lack of services available, the stigma that's involved with having an opioid use disorder, okay, as far as just being an addict and thrown in the hospital and let them go. There's a systematic approach where they're trying to get the people who are in these vulnerable populations to actually gather treatment, okay, and get off the streets into recovery through coaching, and basically overall reduction in costs of the services in the city of Danbury and the greater Danbury for all the overdose responses, because they cost a lot of money. We all know, right? To transport somebody to the hospital, give them the care, meeting that, go into that. All right. On the patrol level or the community level, we're partnering a lot with Stand Together Make a Difference, that coalition, HV CASA, all right? And a lot of it has to do with educating not only the public but the officers as well, that it's not an actual, the stigma of addiction is not exactly all in all criminal, because a lot of the opioids started with prescription drugs. All right? Because 50% of the opioid addicts started with prescription drugs from your doctor, not so much there. No one goes out there and just automatically sticks a needle in their arm and they do heroin for the first time. It just doesn't happen that way. So we've been trying to educate our youth as far as prevention goes into the pathways that lead into opioid addiction through, maybe she'll talk about it with the developmental assets that the kids are lacking. We try to impart those in the schools. The kids that are lacking these developmental assets are more likely to get into the behaviors that cause addictions and substance abuse, as opposed to the kids who have those developmental assets. It's not only from the home, it's also from their environment and their school and their community. All right, so on that, getting into that, prevention programs. Obviously, we'll talk about the drug box. We have a 24 hours, 7 days a week prescription drug box. If you want to get rid of your overprescribed or expired, any type of narcotics, even your vitamins, even whatever, we can put them in that box and we take it and we burn them. Okay, it's the safest way to get rid of them. You don't flush them down the toilet, environmental hazards. Obviously, you want to get them out of your medicine cabinets because it reduces the risk for your teens or to steal them. Okay. Also, we do the drug take back day. And after last year, we collected 462 pounds, which is about almost 2 pounds a day, like 1.7 pounds a day of unused or excess prescription and or over-the-counter type medication. So it's a pretty big deal. All right. And we're constantly emptying it probably about every 5 weeks. And it's a big bucket. It's a big mailbox in the lobby of the police department.
Can I ask you a question? Can you just show of hands who knows about the box? The prescription drug drop box that's permanently installed at the, okay, so pretty much, okay. All right, thanks.
Yeah, we also do a great event with the DEA twice a year, which is better for us because we box it up and they come and take it and they bring it right there. And we did about 200, anywhere between 150 to 300 pounds per event. So if you combine that too, we're doing probably about 1,000 pounds over a year in unused, which is not obviously sitting at home or going back in the environment. It's actually going right and getting destroyed. So it's a positive thing that we can thank HV CASA for helping us to get in that as well. All right, and we'll just go into assistance with schools. All right, we have a great SRO program in all the schools. All right, we work closely again with Stand Together, Make a Difference to actually go into the schools and develop preventative measures. So, you know, the 14-year-olds, although it does happen, and so they're not going right to heroin right out of the gate. It starts as a progression. There's a progression with alcohol, and it goes either with the fruity stuff, and it goes with the beer, and then it gets to the harder stuff, and then when they get to the medicine cabinet, you know, as they get older, because it's, and then they go to college, and now the free stuff isn't available, that's when they start getting hooked on the opioids. So there is a progression. We want to start that earlier on, and give them those developmental assets that push them away from trying to get into these substance abuse type things. So we have a lot of going on that. We do the freshman forum. We teach parents, same thing about the social pressures that these kids face. The parents might know about it because it's all on social media, right? There's other different avenues other than just concentrating on, you know, drugs and stuff. Alcohol is big as well. Social host laws concerning alcohol use. We do a lot of community forums. You know, our job is trying to get out the voice out to the public. We're not just taking you or arresting you, throwing you in jail, and that's it. And that's going to solve the problem. It's not. It's actually it's a big investigative effort as a whole. What we're really concentrating on, obviously, is vaping. I can go a little bit into that. I'm going to take past my 10 minutes.
Yeah. Why don't we go back to
We can go
vaping
back.
afterwards?
That's fine.
Yeah.
Presentation.
Let's do opioids and then we'll go back to vaping, okay? Okay. So Terry, you're going to talk about signs and symptoms?
Yeah, I wanted to take this opportunity to talk a little bit about prevention, since I'm Director of Prevention Services here in Danbury. Our goal is to really impact community behaviors and attitudes concerning use and misuse of drugs and alcohol. So everything we do is with that in mind. And when we think of prevention, we certainly first and foremost go to our youth, as Vinnie mentioned. A lot of our focus is parents and youth and educating and doing media campaigns around and focused to youth and parents. And also when I think about youth, I think about the value of their brains during this unbelievably important time of development. We know that these brains are developing still until the mid-20s. And everything someone puts into their brain as an adolescent can make a difference in the way in which that brain is wired. So it's really important for us to talk to our kids, talk to our neighbors, talk to everyone about protecting this valuable brain, whether we're talking about nicotine, vaping, alcohol, opiates,
pot, doesn't matter, it impacts the brain. Wanted to mention some precursors to addiction, which is chronic, progressive, and ultimately often fatal. Age of onset, very important. The earlier you start vaping, the earlier you start experimenting with drugs, and nicotine, alcohol, it's all considered a drug, the more likely you are to have problems later in life with addiction. And we know statistically that 1 in 3 families suffer with some kind of addiction. So if you just look around the room here and think 1 in 3 of us has someone in their family that suffers from addiction, we know that it's not a pretty sight, it's not a fun thing to go through. And no adolescent decides, when they're young, gee, when I grow up, I think I'll be an addict. That is not anybody's intent, but it happens all the time. So if someone just waits until the age of 21, legal drinking age, to have their first drink, they're 7% likely to suffer from some kind of addiction in their future life, as opposed to if a young person starts when they're 15, 40% likely to suffer from addiction in their lifetime. That's a huge difference, huge. Prescription drugs were not meant to be taken over long periods of time. They were made to help someone just getting over surgery. Somebody with an immediate problem, take it, get over the hump, and then heal. People can be addicted to opioids very, very quickly. And as Vinnie mentioned, a common source for youth with addiction in relationship to opioids is sports injuries. So talk to your doctor if you're taking your child into the emergency room or to the doctor for a sports injury. Talk to your doctor about alternatives to pain management. Don't just assume that they are going to know your child and your background, which is another precursor, genetics. 50% responsible for the risk of addiction. So if you have addiction in your family, your children are more sensitive to addiction. And trauma. Someone added trauma to that list in addition to frequency of use. And I think Gabor Mate said something very valuable about trauma. He said trauma is not something that happens to us, it happens inside of us. And if you live in a home that is experiencing addiction, there's most likely some kind of trauma related, and that should be looked at. In regard to signs and symptoms of an actual overdose, and when we talk about overdoses, we're usually speaking about opiates. Someone very hard to wake up. You shake them, you yell, they're not waking up. When I talk to kids in the schools, I tell them, never just put a pillow under someone's head and hope that they get better. If you're at a party and you see someone passed out, call 911. You can save their life. Your gag reflex goes to sleep when you're passed out, and you can choke on your own vomit and die, because that is our way of getting the icky stuff out of our bodies and the stuff that our bodies don't want. And that is not available when you're passed out. So, clammy, cool skin, blue lips and fingernails, shallow, very slow breathing, very low pulse rate, pinpoint pupils, if you can see the pupils, maybe experiencing seizures or convulsions, and there's no response when you rub your knuckles on the breastbone. So those are some signs and symptoms of an actual overdose, or a potential overdose. And some tips I would like to just leave you with is to please talk to your loved one if someone is experiencing difficulty, and encourage treatment. We really do have things available right here in Danbury. We have outpatient treatment and residential for opioids right at the MCCA. Family Children's Aid treats adolescents in an outpatient and substance use group format, and seek help for you and your family members. Al-Anon literally saved my life. I was dying emotionally and physically, and I didn't realize it. It saved my life. And we have Al-Anon meetings all over the city, Narcotics Anonymous meetings, CARES and the Parent Connection in Newtown have support groups, individual counseling. We've got people that work with substance users as well as family members. And Dr. Rostenberg is going to cover the MAT aspect. So there isn't one treatment that's one size fits all when it comes to substance use for the family or the person suffering from the disease. But seek help and encourage people to seek help. Stay connected with them, show your concern and love for them, and support for them. Connection is one of the most valuable things when it comes to addiction and the person that's suffering from that horrible disease. So stay connected with them and help them through it.
Thank you. We're in the midst of an epidemic here, a public health crisis. In our small state, on average, 2 people die each day of an overdose. This is a major problem, and it has been a problem for the last several years. It's been an all-hands-on-deck approach to try to solve this problem, to try to come up with solutions to this incredible problem. While we talked a little bit about the signs and symptoms of overdoses, not everybody responds to Narcan, naloxone. There's this idea there that naloxone is this wonder drug, and it certainly is. It reduces the effects of opioids, but it doesn't always work. Time is critical. Sometimes we don't get there quick enough. Sometimes a family member will discover a family member dead. And I'm sorry to say that, but the fact of the matter is that we are in this crisis, and Narcan in itself is not the solution. Certainly the ability to get Narcan out in the hands of individuals who are at high risk is one of the many initiatives. We call it harm reduction. You're really behind that effort, but more so it's about prevention and information. When Allison began the conversation with what was happening in Hartford and the information sharing, this is now the norm. We are all communicating around this issue. We have been sharing information with the state and local level. There's now this SWORD initiative, which is the statewide opioid reporting directive, where each time an EMT or paramedic administers Narcan, a call is made to poison control. At the state level, where we're tracking this, where we could look at trends, we could look at what's happening in our communities to get around this issue. In our community here, we administer about 6 to 8 Narcan doses a month. That doesn't necessarily mean we have 6 or 8 Narcan or opioid overdoses. Just means that there's a situation where a paramedic responds and there's an individual who's perhaps unconscious, unresponsive, and we administer Narcan in hopes to reverse the effects of what's happening. We've been tracking this information for several years now, and the trends are actually down in our area as far as Narcan administration. That's a good thing. We don't know fully what the impacts are at the state level because the information is being gathered at the state level and then passed down to the region. What I can say is that we have developed protocols that respond to this particular issue. Our protocols are that it's a multi-agency response to an overdose, which means police, fire department, and ambulance personnel respond to all overdoses in our community for a variety of reasons. We share information, we work together, we're involved in a number of different initiatives to protect the public. In addition to that, one of the things we learned, my colleague to my right will speak a little bit more about this, is that we have to do more. We could potentially save someone's life by administering Narcan, giving them another opportunity for life, but we need to be able to communicate with others in our continuum of care to get them the right care. And this is something we're most happy about, and out of all the initiatives that I've been involved in, I'm the most gratified about this. So the model used to be that we would essentially resuscitate somebody who was not breathing and bring them into the emergency department. They would be watched, they would sober up, and they would leave and possibly do it again. It was this revolving, insane kind of behavior. We looked at this very carefully and said, we need to do more. We need to get other people involved about connecting people to care and sharing information. So our information sharing at all different levels now, among this panel, among others, has gotten much better. And what the yield is that we're collaborating all together to try to get people the best possible care. And that's really what the focus, that's the message that I have to deliver here, is that while the statistics are sobering and they're very frightening, anyone who's been involved with somebody who's overdosed or potentially died, it's personal, it's very upsetting. But we are working very, very hard on this issue because it affects everyone. It is not, all different people are affected by this. It doesn't necessarily affect one population. It is agnostic to that. It is the all equal opportunity killer. We've seen it. We've seen young to the very old dying of overdoses and being basically addicted to all sorts of different opioids. So it crosses all different pathways, and that's why it has been such a specific focus for us these last few years.
Hi, I'm Allison. I have a very unique position at Western Connecticut Health Network, which is now Nuvance Health. I am the opioid patient navigator for the network. And I have two different parts to my position. I look at high-risk individuals in our medical group that have been on chronic opioid therapies for a long time, and I teamed up with our behavioral health consultants, who are mostly made up of licensed clinical social workers, and the psychiatry department, to kind of go into the doctor's offices, see if they work with these patients, and team up with the physicians who are actually treating these patients to see if we can get them a different pain management regimen, whether we can taper them down to safer doses if they are using chronic opioids and they can't get off of them, or offering MAT treatment that is kind of, right now it's not in the works of our medical group. We're really trying to push that through. And Dr. Rostenberg can talk more about that, because I think MAT therapies are really exciting, and it's a way to kind of get someone off of their chronic opioid use with their prescription drugs. Another portion of my position is to identify those individuals in the community who do receive Narcan from EMS or the fire department, And my role there is to kind of follow those patients and navigate them through our health system in order to find treatment, as well as detox programs or any sort of social supports that they need, and to kind of get them clean and sober. I sit on both community care teams, both in Danbury and Norwalk, as well as community work groups. I work in the community as well. So we meet once weekly to kind of discuss patients, discuss the sort of care that they have, and sort of develop these care plans for these patients to get them the help that they need and the supports that they need. A lot of times I will go in to see a patient after an overdose, and they're very frightened, they're very scared, they don't really want to be in the hospital. And I lend a sort of supportive hand to their efforts into getting clean. A lot of the research that I've done with these patients is that they don't have the support systems that they need in place to kind of push them or motivate them to either go into detox or inpatient treatment. And I lend a helping hand in that support. So instead of, going straight into psychiatry or, going into an acute psych unit, it's more or less I'm their helping hand, and I help support them in any way possible. So I follow through with them. I make sure that they're going to their appointments, if anything. I make sure that they have the necessary resources. And right now I'm working with our emergency departments to kind of clear up the little gaps that we have, that we've seen, whether it be patients are leaving the ED and they're not getting a Narcan prescription, or they're not receiving a Narcan kit within the ED. I'm trying to develop a little note card kind of laminated to take with them once they leave the ED, instead of getting pounds and pounds of paper that they're not going to read and throw out. Developing a work card for them so that they have the available resources, a couple here and there, whether or not they need AA or NA, where they can receive Narcan kits within the community, at different resources around Danbury and Norwalk. And then sort of, hotlines which they can call if they've, experienced an overdose, they need to go into treatment, they're trying to find a bed, and I'm able to kind of navigate them through that system and help with their efforts in finding treatment, which I think is really exciting for those individuals who are motivated to get clean and kind of stay clean and sober. So it's really, my role is very unique in the sense of I'm out in the community and I'm doing face-to-face community work with a lot of our clients, and then I'm also on the other end trying to clear up those gaps that we have in our emergency department and link them with psychiatry and EMS and even the police department. We work very closely with the police department. They know a lot of our clients. And get them the resources that they need in order to succeed and stay sober.
Hi, I'm Peter Rostenberg. I'm an internist in New Fairfield. And this is a topic very close to my heart. Let me see. So can you get my lecture? Oh, here it is. Yeah. So far, 400,000 Americans have died of fatal opiate overdoses. Most of these people are young, even though they do go all ages. And each person who dies, for example, our grandson died Christmas morning, 2017. He had over 50 years of potential life to contribute to his family, his community, and to society, which is lost. We're being hollowed out by these losses. And we're not doing everything, but we're doing a whole heck of a lot these people here, I'm really impressed with the work they're doing. One thing we need is more training of physicians. When Suboxone was approved, everybody know what Suboxone is? Okay. Suboxone is an anti-craving medication. So is methadone. They're both FDA approved. They're both World Health Organization's essential medications. There's no reason in the world for them to not be used more. And we're going to go into myths at the other end here. So let me just tell you about these opiate medications. Methadone is what is called a full agonist. It produces euphoria, sedation, think of head nodding, and controls respiration. The euphoria occurs sort of up in the middle of the brain, and the control of respirations occurs sort of at the base of the skull. That is how opiate addicts die. They stop breathing. And if Narcan doesn't work, we can get out the Ambu bag and help breathe for them and keep them alive until we find another treatment. I happen to have trained at Harlem Hospital at the same time that Narcan was approved. And the only way we could do it then was to do, if anybody see Pulp Fiction? Right in the chest. And it worked. But when they finally took the deepest breath I've ever heard, they'd get up, look around, and run out. They weren't ready for treatment. So people like you are essential now. The people I saw at Harlem were admitted to the hospital. This was a wonderful opportunity to persuade them to consider changing their lives. And because of a couple from Newtown, they were able to do this. The year before I started at Harlem, Vincent Dole and his wife, Dr. Neiswander, their drug methadone was approved by the FDA. And so we would see people who were very ill, who didn't get it, and we'd see them again. The people who were in the hospital who got it, we never saw them again. Because this drug made people feel better. Now, I like a quote by a doctor at Yale, Daniel Tobin. He wrote, "Care should be driven by evidence-based, individualized, rational prescribing with a focus on risk-benefit assessment framework." That to me is what all of us doctors try to do. Except when you haven't had training in addiction, we don't train people at Danbury, and for many other places. They don't really understand what to do. They don't know what to do. The government has responded to these prescriptions by constricting the way the prescriptions are written. Yes, duration and strength. But what happens is that squeezes the balloon. And so when these policies were implemented, they thought deaths would decline. The opposite happened. I know of a lady who was cut off from her analgesia, an opiate, at a nursing home, and so somebody brought in heroin, and she died of a heroin overdose. She wasn't a heroin addict. So this is driving people to illicit drugs. We have to have a better way, and I think there's several out there. So I just want to tell you a little bit more about buprenorphine. I love this drug. This drug is a miracle. I've had some people on it 14 years. Their lives have come together. They've married, they've reproduced, they've gotten jobs, they're ascending into jobs, and they were when they started, they were just as desperate, just as fearful as anyone you've ever seen who's been treated with Narcan or is in jail, okay? But the craving disappeared on the Suboxone, which gave them the opportunity to listen and to learn. And we have a rigid program, I guess strict, and they had to come to group, they had to provide urines, and many of them got better. So just last week, after 15 years of doing this, I finally realized that not one of my patients who was an opiate use person who had to go to surgery. I had one lady who, teaching her daughter how to drive. The daughter looked down to pick something up. They ran into a telephone pole, and this patient broke several parts of her back and had to have open surgery. She had the surgery. She had oxycodone. She kept coming to groups. She took newcomers to their first AA meetings. She didn't drop anything because of this. In other words, I wrote no relapse, but the thing that I should have said, treatment works. That's really important. So I'd like to ask, how many of you have friends who are relatives or co-workers who've died because of an opiate overdose? Quite a few. Students here, do you know kids in your school who are abusing drugs? Raise your hands. Okay. Several of you. These people are likely to die unless there's some kind of intervention. So if you have this awareness, I would go to your school authorities and say, hey, look, we got something going on here. And it's likely to be fatal. I don't know when it's going to be fatal, and neither do you, but it needs to be addressed now. So, anyway, I have copies of my something I'm proud of, and forgive me for bragging a little bit. SAMHSA, which regulates these medications, awards a Science and Service Award for office-based practice, opioid practice. And I received that a few years ago. And there are many copies out there that you can take. We also look in the bottom. It says, we follow the National Institute of Drug Abuse principles of effective drug addiction treatment. So if you know somebody you love or just know, and you know they're going to be going to a rehab, you make sure these things are fulfilled. Most rehabs do not provide economically sustainable anti-craving medications and programs. They're either very expensive and they're covered by insurance, but in the office, and this is why we need to train more physicians, in the office, addiction treatment is indefinitely economically sustainable. And it can be as high quality as Dr. Tobin at Yale asked for. So, I'm going to get to some of the myths. And a lot of resistance to this. Some are economically based, some is because everybody thinks that alcoholism and addiction to drugs should be treated the same, and that is not true. Alcoholism generally, when they stop drinking, for a month, and then they relapse. You know, some big thing happens, and they drink, they get drunk. Somebody who is an opiate use disturbed patient who stops using for a month, and that's about as long as you can get into one of these rehabs. If they pick up after a month, they're likely to die because the tolerance very rapidly decreases back to normal. So when somebody can have 20 bags of heroin, when they go to the rehab, when they get out, they really can't take more than 2 or 3. That's just by example. I can't give you the exact numbers of that. So you have to put your foot down when somebody is contemplating going to a rehab, because very often they don't need a rehab. I can't tell you how many young people I've seen who've been to 2 rehabs. They have a second mortgage or a third mortgage on their house, and they relapse. They get into treatment. They never go to rehab again. They don't have to. So here are some myths. Buprenorphine treatment is more dangerous than other chronic disease management. That is such nonsense. I titrate people on insulin to get their diabetes under control. I start people on anticoagulation, often called rat poison, but it works. It saves lives. So that's false. Second thing, bupe is simply a replacement addiction. That too is an insult. And when one of the executive directors wrote an essay in the News Times a few years ago of one of the most famous rehabs, it was disgusting. Because what we do with Suboxone, we restore their mood. We take away the craving. That's what they should get when they're in the rehab. When they get their mood back from the withdrawal, they can think about other things. They can talk to other people. You know, the first sign of recovery from drug abuse or drug addiction, to me, is a smile. That to me is really big, because it means they're developing a sense of humor. That's the first sign of socialization. Addiction is the opposite of socialization. So, the next myth is that prescribing buprenorphine is time-consuming and burdensome. No way, no way. I'll tell you, as you can see, I've been around for a while, and I have a long practice in New Fairfield, and there is no pleasure that I know of when I do a consult on someone for addiction, and they start their Suboxone, and they change. They come back the next day or two, they change even more. This is one of the most gratifying activities I have, and I think it's general, it's not just me. It's like being an obstetrician for an adult. You know, the person's getting reborn. Let's see. Reducing opioid prescribing alone will reduce deaths. Well, I already discussed that. It's actually not working. It makes sense, but it's wrong. So we often discard things that make sense to it as we're growing up in the world and gaining experience. So this is something that needs to be looked at. So I want to see doctors expand their skill set. We have been doing that since Hippocrates' time. We should do it now. And why they have failed to do it, believe me, I've been a pest on this. Why they haven't done it, I can explain, other than a
historic, tragic resistance to improving the services we provide to our patients. So, that's it for me right now.
I just have one more with me. I'm Eileen, and what I do is I work for AmeriCorps in the prevention corps. I go and talk to groups of people that are my age. I'm sorry?
A little louder.
A little louder. How's this? Can you everybody hear me now?
Yeah.
All right, good. Thank you. I talk to senior groups about advocating for themselves, because there are a number of us that, because of our age, we're reverentially respectful to the doctors. The doctors are just people. They're there to help us. So I talk about advocating for ourselves, finding out what's wrong, how are we going to fix it, and they look at you like, wow, I can't do that, until you find out that their friends are very sick or dying because they're taking drugs that they can't think. And we talk about that. I mean, I talk about opioids, but everybody knows about opioids now. The news is doing a wonderful job telling everyone. So I want everybody to advocate for themselves when I talk. And then I also want you to talk to the doctor about what they're prescribing. It's right to ask them what the repercussions are. Is there something else that's not as strong or not addictive that I can do? What can I do to relieve the pain besides these very strong drugs? And it helps us all when we do this. It's not hard. Also, we have bags over here for the people that want to dispose of their drugs, because I also tell them that we can't leave the drugs in our medicine chest for years and years and years. We need to dispose of them. These are very simplistic things for people that are younger than me, because you always did. But then there's a whole generation where we just did what we're told and took what we're told. And that's my job, is to try to tell you we don't have to do that anymore. Let's advocate. Also, if any of you have anywhere, a church group, a book club, a club or organization that you belong to that I could speak to, please let me know. I'll be right here for the duration, and let me know who they are, and I'll find them. All right? Thank you very much.